Let me share my screen.
Yeah.
Oh, great. Okay. So yes, hello, I am Dr. Nicolas Farina and I'm a Senior Research Fellow at the Centre for Dementia Studies. And today I'll be talking to you about the STRIDE project, and STRIDE stands for Strengthening Responses to Dementia in Developing Countries. And specifically, I'm going to talk about one component of STRIDE, which is related to the prevalence of dementia in Indonesia and South Africa. Before I move on to the main presentation, I just want to highlight that STRIDE has got multiple work packages related to anti-stigma, cost and impact of care, situational analysis that span 7 middle-income countries, including Kenya, Brazil, Mexico, Jamaica, India, and really, I wouldn't be able to convey all of this information in a single presentation anyway, but I just want to point you to the website down there on the bottom left, sorry, bottom right, and therefore you should be able to kind of catch up, kind of learn more about the project in general. So the rationale behind this work package in STRIDE was that we kind of acknowledged that in low and middle income countries, we're going to see the greatest increase in dementia cases over the coming decades. And largely that's kind of brought about due to increased life expectancy. And what we're also aware is that many low and middle income countries are under-resourced and fragmented when it comes to healthcare, and dementia diagnosis is generally not seen as a priority for a whole host of reasons. Some of it is due to kind of lack of knowledge or kind of stigma associated with dementia, and others might be due to just not having the appropriate tools to make a formal diagnosis. So obviously we can't just look at kind of healthcare systems databases. We can't just do an audit to see the number of people with dementia. And therefore we're reliant on these kind of epidemiological studies to better understand what the prevalence of dementia is. And through our conversation with policymakers and using theory of change workshops, we essentially, we kind of identified that what policymakers want is to see data derived from their own country. They don't want to see data that's derived from a geographically close country because it's easy for them to be kind of negative or dismissive of the data and what it actually shows within their own setting. And so hopefully the data that we generate here will feed into those policymakers, and so that they can adopt new dementia action plans and make dementia a bigger priority within their agenda. The overarching aim of this work package was to generate new evidence about the prevalence, costs, and impact of dementia in Indonesia and South Africa. And today I'm only going to be talking about the prevalence component. So this is all very new data, and so it's kind of hot off the press. So really, I will talk about the prevalence component, but just to be aware that we do have a whole other separate components related to costs and impact as well. So the actual methodology behind STRIDE is that actually we kind of set out to recruit 2,200 older adults in each country. In Indonesia, we were recruiting from Jakarta and North Sumatra, and in South Africa, we were recruiting from Limpopo and Western Cape. And these regions were selected for a whole host of reasons, but the kind of the key priority here is that we wanted to make sure that we kind of had a heterogeneous group of people. We wanted to ensure that we didn't just have people living in urban settings. We didn't just want people who were highly educated. We wanted a variety of participants to help kind of improve the generalizability of our findings. And within each of these sites, we essentially sought to find those aged 65 years and older, and we did this through a series of kind of random sampling methods. So depending on which site was dependent on whether we had pre-existing population-based databases or whether we had to do kind of random walk door knocking. But essentially we randomly selected older adults in certain geographical areas, and then essentially we kind of administered a series of questionnaires. Primarily, or what's most important for today's talk, is a kind of this diagnostic toolkit, which is the 1066 short schedule. And really, we chose this toolkit because actually, well, first of all, it's been shown to have good accuracy when you compare it to a clinical diagnosis. So, so against, say, the DSM-4, for example, but also it's been found to be quite, it's found to be quite education fair as well, education and cultural fair, and it's been administered in multiple countries worldwide. And really, one of the motivations to choose this tool over, say, others was that actually we wanted to ensure that we had kind of a pragmatic means of kind of estimating diagnosis rates, because actually we didn't want to have to draw specialists away from their clinical responsibilities to kind of have to take part in this study to make these diagnoses. So actually this is something that is going to be able to be implemented in many countries, this type of toolkit. So just well-trained researchers rather than getting frontline clinicians to make these diagnoses. So before I kind of move on to some of the data that we generated, I think Dr. Hicks earlier had a very similar slide. So essentially we were meant to begin recruitment in probably March 2020, which kind of lovely coincide with a certain pandemic. And actually what we found is that instead of having probably, say, 6 to 9 months to recruit these participants, we kind of got whittled down to probably about 3 months, because we wanted to make sure that all our research was going to be safe for both the participants and also the researchers. Anyway, so essentially all this data has been collected between, I think, October of last year and December last year, so three months. And really, the science did amazingly well. So in Indonesia, we achieved the recruitment target of 2,200. In South Africa, a bit less, but still very impressive. Really, I'm not going to make too many kind of big statements based on the demographics here, but I suppose the key thing to note here is that we're looking at about 40% of the sample that we interviewed didn't have any formal education. And possibly quite interestingly here, that in Indonesia, we see that 64% of the older adults reported having some subjective memory complaints in comparison to 21% in South Africa. So that's something that's interesting and may contextualize some of the findings that I'll present next. So from within Indonesia, what we find is that the diagnostic algorithm generated a prevalence rates for the over 65s at 23.4%. Now, for those of you aware of the general literature, we might say, well, actually, this is quite a high percentage, and you'd be right. So typically, lots of global estimates of dementia prevalence sits probably closer to 4 to 5%. But actually, when we look at some of the more recent prevalence studies that have gone on within Indonesia, we see that actually other studies have found this elevated prevalence rate. So I think there's one study that found 20.1%, and another study as high as 30%. So that's just something to consider. And then when we look at South Africa, we also have a slightly, again, elevated prevalence rates based on this diagnostic algorithm. And again, slightly higher than what we would expect, and higher than some previous estimates that were kind of between 6 and 8%. So obviously this is very new data, it's only very recently analyzed, so we do need to look into it further. And actually, we need to kind of understand why these prevalence rates are higher. Is it because of actually the population that we've kind of captured, even though we've taken steps to get a random sample? Is it because that they have a high number of risk factors there? So obviously there could be things such as like sensory impairments, it could be education levels, it could be a whole host of things. And obviously Darina talked about lots of risk factors this morning. So all of those could potentially be in play to result in that elevated prevalence rate. There are also there's also arguments that the 1066 schedule is one that is probably, it might be more sensitive to earlier or picking up those earlier stages of dementia. But obviously that's something that we need to look into. And finally, it could also be that another explanation for this is actually how education fair is the tool. So there is lots of evidence before saying that this tool is education fair, but maybe it is the fact that we do have quite a high proportion of our sample that has very little education background, and that could be potentially biasing the actual kind of cutoff points within this algorithm. But moving forward, we've got lots more analysis to do. So something that we tried to do from the outset was to ensure that we had this holistic set of outcome measures. I think Professor Banerjee kind of highlighted early on that lots of research focuses on cognition and function, and we wanted to kind of take steps further than that. So we've got a whole host of outcome measures spanning from stigma to elder abuse to carer burden, and obviously lots of interesting analysis to come forward to look at what how people in these countries are living well or poorly with dementia, and potentially being in a situation where their diagnosis is unrecognized. And finally, we wanted to, or we plan to at least, to kind of share all of the standard operating procedures that we generated, the code books, the syntaxes, the translated tools, because we spent a long time translating a variety of measures. And really, we want to ensure that other researchers in the future can adopt them and build upon our methodology so that they can implement within different regions and different contexts. So at this point, I just want to say thank you, particularly to our funder, but also to the collaborators all the way around the world, particularly collaborators at the University of Cape Town and the University of Atma Jaya in Indonesia, and because obviously they did a brilliant job of recruiting in such difficult circumstances. So thank you.